So it's known by a lot of different names. A lot of this talk has already been covered previously, just in this afternoon, in terms of treatment, also the other neurological conditions. So I can skip over some sections. In terms of definition, what it is, it's basically the talus becomes vertical and the navicular becomes dislocated dorsally, and it's a rigid dislocation with equinus of the calcaneus, and it's characterised clinically by rigid dorsiflexion of the forefoot and also fixed equinus of the hindfoot. So there's a model over there in question 5 that everyone's already looked through. Oh, sorry. So anyway, this is what the kid's foot looks like. A bit cartoonish, actually, in terms of a rocker bottom midfoot. We'll talk about more of that later. Just the demographics, it is rare, so they reckon that for every 100 clubfoot, you get one vertical talus. It's about equal in both sexes. It's bilateral in half the cases, and 50% of them are an isolated deformity, so that means they're idiopathic, and about the other 50% are associated with these following things. So central nervous system, neural tube disorders, things like syrinxes, myelomeningocele, muscular, ischiocalcaneal bands, tight bands of muscles which cause equinus. Acquired, you can get polio or cerebral palsy, iatrogenic. So they mentioned that overcorrection of clubfoot can lead to this condition, and then genetic, noted to be autosomal dominant. And finally, the biggest cause is idiopathic. In terms of pathoanatomy, there are 4 basic abnormalities that you can think about, and they're divided up to bones, joints, ligaments, and muscles, and these are nearly always present. So I mentioned earlier the navicular bone dislocates because the talus becomes vertical. The talocalcaneal and CC joint can subluxate. Tib post and peroneus longus, or the peronei, can subluxate anteriorly and essentially become forefoot extensors. And then the intrinsic muscles. So what it means is the hindfoot becomes rigid and the posterior third of the talus essentially articulates with the tibia. The forefoot becomes pulled by the unopposed extensors, and the foot becomes everted by the peronei. This is, I guess, someone who's grown a bit older with this. So clinically, often walking is not delayed, but they do walk funny, and they get a large callus over the medial part of their plantar aspect, which is actually the talar head driving down into the plantar aspect. So they described it as a peg leg gait. So I guess they walk like little pirates. Although 50% of them do have both, so I don't know how they walk. Because essentially the foot's fused, so I guess there's no bow-off in stance. And clinically, deformity consists of hindfoot, midfoot, and forefoot deformities. So the hindfoot's in equinovalgus, the midfoot's got a rocker bottom, and the forefoot's abducted and dorsal legs, and the toes are clawed. Plus, they mentioned these following things. So medial column is long, the lateral column's abducted and concave, there's tight tendo-Achilles, and there's a prominent talus, usually with a callus present. One of the descriptions they use is a Persian slipper. So this is the lateral side of the foot. This is the callosity, or the prominence they talk about with the talus. So I borrowed one of Aaron's slippers. And I can't really see the resemblance, but I guess if you look hard enough. Oblique talus. There's a slight differentiation between oblique talus and vertical talus. Oblique taluses are usually a milder form because the foot's more flexible, and there's better prognosis, traditionally thought, with non-operative management. The diagnosis between the oblique talus and a vertical talus is made via a lateral plantar flexion X-ray, where the talus becomes aligned once the foot gets put into forced plantar flexion. So what other things could it be? There's a congenital calcaneal valgus foot, which is a packaging problem, I guess. Absence of fibula. All the other things are pretty rare. And finally, overcorrection, or iatrogenic injury. So this is pictures of a calcaneal valgus foot. Usually it's because the foot's pressed up against the uterus, and this is a true vertical talus, and you can see this foot doesn't have the rocker bottom deformity that this foot has.
It's a key slide, looking at those. Tell me the calcaneus, or the calcaneal valgus distinction from the rocker bottom is really essential. Rocker bottom has a high.
Because the treatment for these is very different. This one just sort of resolves by itself with a bit of massage. Investigations, x-rays, AP laterals in dorsi and plantar flexion as well, and you can measure all these fancy angles off them. Some people suggest ultrasound and MRI, but not as first-line treatments, or not as first-line investigations. I guess if there's something weird going on, a syndromal, we can consider MRI for the back and the head as well. Just to remind myself, radiologically, the ossification times of these bones. So the talus and the calcaneus are the only things ossified in the hindfoot. The cuboid becomes ossified at 1 month, and the navicular usually 2.5 to 5 years. So often you can't see these on the initial x-rays. I don't know if that projects very well, but on the AP you can measure a kite angle, which is a talocalcaneal angle. It's pathological if it's greater than 40, although a lot of these are borderline in congenital vertical taluses. On the lateral, this is usually where the money is. So these two angles here, they're called talar axis metatarsal base angle, or first metatarsal base angle, and it's essentially looking at the talus and the metatarsal base and the angle they make, and this is calcaneal angle, metatarsal base angle. A suggestion of what normal should be. Here's an x-ray of the foot in forced dorsiflexion, plantar flexion, and you can see that this is still quite dislocated. So this is a case of congenital vertical talus by putting the foot into a flexion. If the talonavicular joint was to reduce, then it would be an oblique vertical talus, and also to be noted is the fixed equinus. Management, so principles are to establish normal relationships between the bones and then to hold them there. A lot of the treatment depends on age and severity. I think the older idiom was to, or the older treatment philosophy was non-operative results are usually poor because the foot's very rigid, and they usually reoccur. So yes, you can look at these things depending on the different stages the kid's at, how old they are, and how severe the deformity is. Arbe's already covered a lot of this earlier on. So open reduction of the joint, soft tissue releases, transfers, often tibialis anterior to the talar head, and these are essentially for quite late cases of arthrodesis and also talectomies. And often these are applied with a combination of casting. Now, recently though, this is a JBJS article from 2006. It's been proposed that casting alone with some soft tissue procedures do just as well for congenital vertical taluses. So these are not looking at the ones that are neuromuscular or very, very rigid. The congenital ones or the idiopathic ones, what they're looking at. And published out of St. Louis. Essentially what they propose is do exactly the same for the vertical talus as you would for the club foot, but in reverse. So all the deformities they have in the vertical talus, you correct by inversion, plantar flexion, and adduction. So you essentially put them into a club foot. And you do this for a period of about 5 weeks or so, or 5 castings, before you try and stabilise them. So just quickly go over the study. They did a series of 11 kids with 19 feet, and it's consecutive. I've written that twice. It's obviously really important, and only idiopathic. So they first of all cast them until the talonavicular joint becomes reduced, and once it becomes reduced, they stabilise them and do a Achilles tenotomy at the same time. Because one of the things they don't address is the equinus of the hindfoot to start with. There's a couple that did fractional lengthening as well. took about 5 casts, and if they went above 6 casts, they went on to do a percutaneous or an open induction of the talonavicular joint. And the rest of them did very well, essentially. So in total, 6 feet and 3 patients had reoccurrence, but none of these were actually stabilised with a K-wire. For everybody who stabilised with a K-wire, nobody reoccurred at 2 years. So in summary, it's quite a rare condition, about 1 in 10,000. There's lots of different causes, and the most obvious deformity is rigid rocker bottom deformity. So in treatment, if it's early and if it's picked up early as idiopathic, then the reverse Ponseti casting seems to be the way to go. So in terms of bibliographies, I had a look at quite a lot of them. These 2 articles up the top there are quite good just to get.
Question?